We'll move to our next speaker now. I feel very honored to introduce Dr. Dori, who's going to speak about the lymphatic system in single ventricle. Dr. Yoav Dori is an interventional pediatric cardiologist, and he's the director of the Jill and Mark Fishman Center for Lymphatic Disorders and Lymphatic Research at the Children's Hospital, Philadelphia. Dr. Dori is going to share his experience with the lymphatic system in single ventricles. Thank you so much, Dr. Dori, for joining us.
All right. Can everybody hear me? Can you hear me, Adam?
Yep, sounds great. Thank you.
All right. So first of all, I would like to say congratulate Ellie for that. Just amazing talk. It's inspiring to see patients who have this kind of attitude, which really is it's unbelievable. And the good news is I'll be giving a talk to show Ellie there's help coming your way. There's help for this disease, and we'll be talking a little bit about it today. So I'll introduce what Ellie's problem, the problem of protein losing enteropathy, how it's caused, and we'll talk about some of the therapies, and we'll talk just about the lymph system in general. But this is really one of the crux of the problem in patients with single ventricle physiology. And I don't have any disclosures. So lymph system is as this is just a quickly introductory slide, is a circulatory system. The flow is in general is from the periphery, so from the different organs centrally towards the thoracic duct, and in most people fluid drains from the thoracic duct into the subclavian IJ junction on the left side. There's variability to that. There are two very important lymphatic streams, especially in patients with heart failure, and one of them is coming out from the liver, shown on the left side over here, and then one is coming out of the mesentery. Both of them are involved in what Ellie just described, her symptoms of protein losing enteropathy, and we'll show a little bit about what that looks like in a second. Normal people flow in the thoracic duct is about 2 to 3 liters a day. So if you're born and you have normal central venous pressure, then you have normal production in the liver, and you have normal drainage out into the veins. And again, about 2 to 3 liters a day. When you take a patient and turn them into a gland, which is shown here, now I always describe this to patient as equivalent to taking a finger and putting it on the edge of the garden hose. So now you've increased the pressure that the lymphatic system has to drain into. So it makes it harder to do that. And we start to see then lymphatic congestion as a result of that. And when you convert them from a gland to a Fontan, now you've done 2 bad things to the lymph system. Is you've increased production in the liver because the CVP is the preload. So that is the pressure that pushes on the tissue inside the liver that causes lymphatic production. And that causes a marked increase in lymphatic production. It can go from 40% of central lymphatic flow for, let's say, 1 liter a day up to 15, even 30 liters a day in severe heart failure. So you have poor drainage and increased production, and that ultimately can lead to problems. But in addition to the abnormal physiology, there is an abnormal, probably susceptibility in anatomy. The reason why Ellie, for example, has protein losing enteropathy with probably very good Fontan pressures, while some other patients with very bad Fontan pressures don't have this disease. So there's probably some kind of an anatomical or some variation in the lymphatic channels themselves that make you susceptible to this. And over here, it's shown what we call the pulmonary lymphatic perfusion. It's the susceptibility to having lung problems, and there is a susceptibility to having liver problems, or not liver, excuse me, duodenal problems. And that's what Ellie is experiencing, and we'll show what that looks like in a second. We'll talk today about a few types of imaging, so I just will quickly introduce those. This is just simple imaging. It's called T2 imaging. Everybody can do this. We use this for screening, and this is what normal looks like. So it should be mostly dark, just a little bit of fluid in the stomach over here, and you'll see the spinal fluid, but I cut it out. And then there's the dynamic imaging, or lymphangiography, dynamic contrast lymphangiography. This used to be the main way that we used to image these kids, which is just accessing lymph nodes in the groin. And this is what the thoracic duct looks like. This imaging technique has really changed everything about our understanding, because if we're dealing with a circulatory system, we have to be able to understand flow, we have to be able to understand pressures, and we have to be able to understand anatomy. And this is the first imaging technique that really allows us to do this in real time. And this is what a normal thoracic duct looks like. This imaging technique doesn't really help with protein-losing enteropathy, except for very specific types. And for that reason, we developed these new techniques that we now use on all single ventricle patients that are coming to us. So if you're a single ventricle patient, whoop, what's that? There you go. Hold on. There you go. So if you're a single ventricle patient coming for a lymphatic procedure in our institute, you're going to get this type of imaging also. So this is intrahepatic dynamic contrast angiography. So the same thing, but we're injecting in lymphatic ducts in the liver, which for Ellie, this would be a diagnostic procedure and will tell us exactly what the problem is. And you can see this is kind of what normal looks like. We're injecting up in the liver on the right side of the patient, left side of the picture, and you can see the retroperitoneal lymphatics light up and then the thoracic duct light up, and it's going to the left side. There's a new imaging technique this we published about, and there's a new imaging technique that we just published about, which is called intramesenteric dynamic contrast angiography. Again, plays a role, very important role in ascites, a role also in certain forms of protein-losing enteropathy, and I'll show you what that looks like in a second, but that's just accessing lymphatic channels in the mesentery, and you can see this is what the mesentery looks like, and then connecting to the thoracic duct. So we basically now have the ability to routinely image really the three most important compartments for lymph flow. And that, again, is changing a lot about what we understand about how all this works out. When we talk about lymph failure and with what Ellie is experiencing right now, right? So we talk about the known ones, which are protein-losing enteropathy, plastic bronchitis, and chylothorax. But there's also lymph failure, and we know now that it's that it plays a significant role in this of developing ascites and edema, even if you don't have PLE, plastic bronchitis, or chylothorax. And there's probably also a role that lymphatics is playing in the end organ damage, which is really the biggest problem that single ventricle patients who survive to adulthood are going to experience. And all of them are going to have a certain degree of this. And we've always thought that this was just the cardiovascular or the CVP causing this, but really that's, I don't think that it can explain this fully. I think lymph is playing a very significant role in this. Ultimately, we have to develop the lymphatic diagnostic tools and treatments in order to deal with all of this, because this is really, I think, the crux of the problem for single ventricle patients. There's many of them are going to experience symptoms related to this. Lymph failure occurs not just centrally, which is what we will talk mostly today, but also it can also occur peripherally. And my colleague and very close friend, Vibeke from Denmark, who's a spectacular surgeon and lymphologist, and her entire team, they deal a lot with peripheral lymphatics, and this is her wonderful work that was published showing that even peripheral lymphatics are dysfunctional. So when Ellie was talking about edema, for example, this is the reason why she's experienced some of that, in addition to the low albumin that she has. But even if she doesn't have low albumin, you will start to develop a dysfunctional peripheral lymphatic system. And they've shown that using the techniques that they use, injecting isocyanide green into the peripheral lymphatics and using laser camera, and they can see that the pumping pressure, for example, in Fontan patients is lower than controls. And if you just think about it in the context of the heart side, right? If your heart is not pumping, right, then you're going to have to increase your heart rate, right, in order to get your cardiac output. So to increase your lymphatic output, right, if you're not pumping as strong, then it makes sense that you'll have to increase your pumping frequency. And that's what they have seen. And that's exactly what happens. And then there's other abnormalities with refill time and velocity. So this wonderful work is continuing, but it shows us that lymphatics are abnormal everywhere. It is not just centrally. Sorry, there's a little delay in the, here, let me get that, there we go. Good. When we talk about failure of the central system, and we'll concentrate for a little bit on the chest, and these are the three things that we think about. It's the chylothorax, chylopericardium, and plastic bronchitis. As far as I am concerned, they're pretty much the same thing. It's just a matter of where the fluid is leaking. Is either leaking to the pleural space, around the pericardium, or leaking into the airway. But the cause of the problem is pretty much the same thing, and this is what we call this pulmonary perfusion or abnormal perfusion. Now, we can see this abnormal perfusion in utero. So using the T2 sequence, if you image a baby that has abnormal stuff in the lungs, this perfusion that you see over here, you'll see this nutmeg lung, and this is right-sided nutmeg lung. This kind of pattern that looks like a nutmeg apparently. And this correlates perfectly with what you see over here with the dynamic imaging. In the right lung, you see this flooding of the lung. And this is what causes plastic bronchitis and chylothorax and all that stuff, because you have abnormal retrograde flow in the lung lymphatics. And they cause lymphatic channels in the area that they're flowing to be engorged. And if you think about it, right, you have liters of fluid a day going into the lungs, and this can cause many different kinds of problems. Including the ones that we talked about, right? Your lungs are never going to be optimal. They'll always be wet. You'll need diuretics. That was in utero showing what it looks like. But if you're a baby and you're born, right, and you do T2 imaging, then this is what the lungs will look like, right? So the lungs, as I said, are going to be wet. And this has enormous consequences, especially for single ventricle patients that are really going to be dependent on their lung health in order to make sure that we can get the blood across there. So this is a newborn baby, is not a Fontan yet. And that's why it's not just the Fontan that is causing the problem. It's exacerbating a problem that already exists. This is, again, a newborn, has a sano, I think, or a shunt. And you can see wet lungs, T2 imaging, and that correlates perfectly with this abnormal pattern. This baby has a very abnormal pattern with diffuse intercostal flow to both sides and diffuse flow in other directions. So this, again, is T2 in a baby. We've used this T2 imaging, and we use it now to screen all patients. So, and I keep on saying this, and people are now doing it, and that's great, because really T2 imaging is probably the most predictive imaging that we do to tell us which patients are going to be able to succeed through the Fontan pathway and which ones won't. Once you have taken care of all the cardiac sites, so if you're coming to the Fontan with, you know, reasonable pressures, with a heart that's functioning and your valve is not leaking, then this really tells us better than anything else, I think, is how you're going to do. And if you have this kind of abnormality on T2, what we call a type 3 abnormality, which I think there's arrows that go with that. But a type 3 abnormality, yes, that has abnormalities, lymphatic abnormalities in the mediastinum, and a type 4 where it extends into the lung, then this has a very strong predictive value about what you're going to do when you become a Fontan. And again, this is just the lung component, right? So if you are a type 3 abnormality, you will proceed through the Fontan. You will most likely have effusions after the Fontan. You might need treatment, you might not. The effusions might go away. If you're a type 1 or 2, you're going to fly through the Fontan. If you're a type 4, and that's the greens over here, then you are going to not do very well. Okay? Most of them did not succeed at this point. When we were looking at the data to get through the Fontan, they were the ones that had the mortality of the transplant. There were no mortality and no failure to get through the Fontan for any of the other groups. So extremely important to know. Now, the question is what happens if you treat them. And we've now treated multiple patients with type 4, and I'll show you, I think I have a little bit of the data, or maybe I didn't add them, but we've been able to take some patients with type 4 through the Fontan. So I think it's possible to do that, but you need to clear the lung. Now the question that we've had, and again, Vivica is going to be doing all this work. This was just a patient that we saw last week again, and I just looked at the imaging, but is what happens to T2 abnormalities as we go through the years. And this is a patient that we've done T2 imaging because we started to do this routinely. So any single ventricle patient in our institute who comes to MRI gets a T2 sequence. So they get it as a baby, no matter what. All single ventricles get it. And so this is from 2012 to 2020. And this is a healthy Fontan, really not too many problems. There's just surveillance imaging. And you can see there's some T2 abnormalities. There's some stuff in the supraclavicular region, but really not a huge change in the T2 signal that is surrounding the arch over here in the mediastinum and the stuff that's in the supraclavicular region. Now that's in contrast to the patient that I'll show you now. This patient came to us in 2013, had some ascites already, started to experience what I call the lymphatic failure, but had actually PLE at the time already, but did not have ascites at the time. And you can see the supraclavicular region, and that's the images on the left is from 2013. The supraclavicular region has a little bit of brightness, but is not too bad. And you see what happened in 2016 when the patient now has severe PLE and severe ascites and fluid in the chest also. And you can see that the supraclavicular stuff has now grown as there's more networks over there. So clearly there can be progression. And one of the questions that we have, right, is can we actually predict by looking just with T2 imaging at the progression of the abnormality? And that will tell us who in the future is potentially going to fail, and get into this kind of a trouble. And again, Vibeke is going to be doing this work and hopefully help us figure this all out, Vibeke and her team. Second, get to the next slide. Oh, yeah, next slide. Good. So, as I said, all patients that come to us for MRI get T2 screening. All patients that are coming for dynamic imaging are also getting, as I said, intrahepatic imaging, and in most cases, mesenteric imaging. So if you just have plaster bronchitis, you might not get mesenteric imaging, but you will absolutely 100% are going to get intrahepatic imaging. And this is the reason, because we think that potentially intrahepatic imaging can tell us if you have the susceptibility for protein-losing enteropathy. These are patients. This is a patient on the left over here. You can see the duodenum is dark. Even though we injected the liver, it's lighting up. This patient had plaster bronchitis, but the duodenum remains dark, so it's not perfusing the duodenum. And that's in contrast to the patient that it's on the right over here. In this patient, the duodenal wall lights up, and we think that this is the susceptibility to protein-losing enteropathy. And if you see that, then you have to be very careful, and those are the areas that I was talking about. Then you have to be very careful about what you do and what kind of intervention you do, right? So shutting down the duct in these patients doesn't make any sense. This is data that we've now collected. We've finished writing the paper, so this will be submitted now, about all the patients that have come to us and had intrahepatic imaging. And that was a while ago when we collected this. There's many more of them now. But you see that all patients with protein-losing enteropathy, which is the one in this orange color, right? Almost all of them have leak into the duodenal lumen. There's a few, 3 of them that had just duodenal wall enhancement without leak. You can see that patients that don't have protein-losing enteropathy, almost all of them do not have enhancement of the duodenal wall, but 2 of them did. And that is consistent with the data that we have on patients, for example, with plaster bronchitis, that about 20% of them will have concurrent PLE and plaster bronchitis or chylothorax and PLE at the same time. So this data is consistent with that. And this is this multi-compartment problem. Oh, just a second, I think I clicked. Yeah, let me go back one. Just a second. Okay, yeah. So this is our data for chylothorax. Again, this pulmonary perfusion. You can see the image here is chylothorax. You can see the networks in the supraclavicular region. Chylothorax, as is plaster bronchitis, which I will show you in a second, we published about this, is a very treatable problem. But our thought process about how to treat it and what to do with it has changed now that we've started doing other imaging techniques and have changed our thought process about what constitutes lymphatic failure. We have done like thoracic duct embolizations routinely, tried not to, but now we really go out of our way to make sure that we don't do that, although we still in some cases have to do that. But almost 100% of the cases, and this is this pulmonary perfusion, very few patients with single ventricles will have a leak, so we're not going to even talk about them. Out of these 16, there were only 2 leaks. CLFD is a multi-compartment problem that did not survive back then. We now have a way to treat them, and I'll show you what that looks like a little bit later on. But chylothorax is a very treatable problem. We should, in 100% of them, we should be able to treat them, as is plaster bronchitis. And this is what plaster bronchitis is again, is just spilling of protein into the airway, which ultimately cause these casts. This is the peribronchial lymphatics. You can see here in blue from injection of blue dye into the thoracic duct in a patient with plaster bronchitis. This is the outcome for these patients. They cast regularly when they come to us, and almost all of them stop casting immediately after treatment. There were some that continued to have a few casts, and that the reason for it, and in almost all of them, I think that is the case, is that you can have these other kind of connections, which I'll show you in a second. But again, as I said, right, screen, this is a patient again with placid bronchitis, and you can see this patient, no diagnosis of PLE, has a leak into the duodenal lumen. And we did an alpha-1 antitrypsin, and that was negative. So this imaging modality is probably better at diagnosing and more sensitive for diagnosing PLE than the alpha-1 antitrypsin is. But we will follow this over time, and that will tell us. But because of this leak into the duodenal lumen, we did a selective embolization using a balloon technique inside the ducts, which we won't go too much into right now, but we're able to salvage the duct in this patient, which we think is very important. This is these hepatopulmonary connections, which you can have. You can have the liver connected directly to the peribronchial lymphatics. You can have them connected to the lung in any place and causing leak. And we can treat those. So there's a way to find it. This is dynamic imaging in a patient that had placid bronchitis, very bad placid bronchitis. And you can see there's no abnormality in the chest. So there's absolutely no reason to touch the duct in this patient. And we did not. What we did is we found the the liver channels that were connecting to the lung. So this is a needle in the liver, and embolized it. And since then, this patient's placid bronchitis has disappeared. So we pretty much, I think, can treat almost all of them. PLE is what Ellie was talking about, and I'll end with this, so just a few more minutes. PLE is this, is instead of liver lymphatics that are going towards the cisterna chyli and then draining, is liver lymphatics, because liver and duodenum are anatomically close to each other. And what happens is that at some point, probably the liver is producing too much lymph and overtakes the duodenal lymphatics and starts to flow retrograde. Same thing as like the pulmonary perfusion. This is duodenal perfusion, ultimately leaking into the duodenal. And the duodenum is a very big space. You can leak and leak and leak into there. And ascites also is involved with some version of this retrograde flow stuff. But PLE is really this. And as I showed, right, intrahepatic imaging, 100% of them will either have leak or perfusion. There's no patients that we've ever done that did not have this. In this patient, you can see leak into the duodenum from liver injection that then refluxes back into the stomach, excuse me, and then refluxes all the way up into the esophagus and comes out of the mouth at some point. So this is protein losing enteropathy. This is the other imaging modality, the intramesenteric, which we do in all patients with PLE. This is a new patient that we just did, and this is another reason why we should not shut down the thoracic duct. So this patient, unfortunately, had a thoracic duct ligation, not by us, very bad PLE, and with mesenteric injection, same thing, right? We inject the mesentery over here, and the duodenum is filling, and the stomach and the intestine filling. So you get these circuits are all connected to each other, right? The area of the pancreas and the duodenum is really the eye of the storm. And if you don't have a duct, then you're forcing the fluid from different places to go there, and that's a problem. This is what PLE looks like from the inside. So these streams that you see with the arrows over here, that is lymph from holes in the duodenum that is leaking in. And if you inject blue dye into the liver, you will see it spilling into the duodenum, and that is protein losing enteropathy. That is 100% of these patients. This is exactly what they have to a different degree. And we can treat this now. So there's different kinds of treatment. This is a patient that actually just came to us last week. And you can see this, and the problem with some of this is that anatomically things are close to each other. So in this case, we had contrast in the common bile duct, which you can see. But we got into the network that was causing protein losing enteropathy, which is right behind the pancreas. And you can see, and I think there's arrows actually to point towards this. There you go, that these were holes in the duodenum, and you can see the fluid going in there. And so we got into these networks and we glued them, and you can see that when we did the gluing, these big blobs coming out, and that is coming out of those holes that are in the duodenum. And you can see all the networks around the duodenum filling. And this patient was on constant protein transfusions and all those things, and his protein now has completely normalized, and he does not need any transfusions anymore. So there's one way to treat this. And we are working on now collecting our data to give you the outcomes for these, but we have been able to stabilize, even for years, patients' albumin using these kind of techniques. And then there is this multi-compartment failure. And if you have multi-compartment failure, either as a baby or older, This is a big problem. But even for this, even multi-compartment lymphatic failure, where you have stuff everywhere, there's ways to treat it. One thing to make sure is that if you are a baby that has this, make sure you don't let anybody touch the thoracic duct. Very important. For older patients who have this, so have PLE, ascites, have a leak into the chest, there is the Hiraska procedure. So this is a decompression procedure that can be done surgically and can also be done percutaneously. And you'll see that on the next slide. So this is a percutaneous, there's a percutaneous approach for every single anatomical variant that we currently have. And we've done it, and Jack is working on writing that up. So you'll see the different variations to this theme. What we have found is that if you don't do a lymphatic intervention for before you do the decompression, then in some cases it does not work. So what we do for all patients is we shut down the big leaks and then do a decompression if we need to. And in most of them, we can get them out of the hospital, and actually they can look really wonderful, even though they're presenting with horrible edema, ascites, and all the rest of the stuff. So I'm sorry I took a little bit long. I'm going to end with this, just saying is that lymph flow disorders are obviously serious, but there's a lot of hope for these patients now. Our understanding is increasing. Everybody's getting involved. And as long as we do that, I think we give Ellie, a good shot for a bright future. And just thank you again for inviting me, and I'll be happy to answer questions later.
Thank you so much, Dr. Dori. Great presentation. I learned a lot from that, and I'm sure our audience did as well.